involved with RSN for nearly 15 years. Support from someone who's been there makes all the difference.
Hey David, what are you listening to?
Kidney Talk, an online radio podcast that talks about kidney disease and the prevention of it.
Oh cool, where can I find that?
Oh, you can download it on iHeartRadio, Google Play, and Apple Podcasts.
Oh nice, I'll definitely have to download that.
Shout out to Renal Support Network, the annual Renal Support Network essay contest. I won the Renal Support Network contest last year, the Warrior, and we are all warriors. So thank you, keep on doing all that you do, and be happy and healthy and keep the hope. Thank you, Renal Support Network, woohoo!
As a kidney transplant recipient, I find that having an actual publication like Kidney Talk is an invaluable resource for any kidney warrior at any stage.
RSN keeps me informed of kidney advocacy issues so my voice can be heard.
I'm really looking forward to the prom this year and meeting people who are just like me. Dressing up is super fun and all the activities are amazing. Can't wait to see you there.
Hi, I've been participating in the Renal Support Network 30-minute fitness Zoom classes. Not only have I lost 15 pounds, but I can also strike a yoga pose like this.
When I created Renal Support Network back in 1993, I had no idea the impact that I would have among my peers. An illness is too demanding when you don't have hope, and peer support, education, and knowledge are crucial to our survival. We have a great week planned with some incredible speakers, great information for you to share, learn, so we can survive and thrive with this illness. It's imperative. So stay tuned. We're going to have a great event, and a shout out to our corporate mission partners for making this happen. So our next speaker is Dr. Benjamin Hippen. He is a clinical professor of medicine at the UNC Chapel Hill School of Medicine and a general and transplant nephrologist with Metrolina Nephrology Associates in North Carolina. Dr. Hippen is the Associate Medical Director of the Kidney and Kidney Pancreas Transplant Program at Atrium Health. Dr. Hippen is the author of more than 50 peer-reviewed manuscripts and previously served as Associate Editor of the American Journal of Transplantation and the editorial board of the Journal of Medicine and Philosophy. I think we're going to like this, Doctor. I like the word philosophy because of the fact that, you know, we all become philosophical when we're dealing with end-of-life issues. So welcome, Dr. Hippen.
Well, thank you very much. And I just want to second the sentiment of what an honor it is to have the opportunity to speak at the Renal Support Network. And I'm very grateful for the invitation. So my talk today is, thanks to the title provided by Lori, Getting Listed for a Transplant, What to Do and What to Know. I will walk through my own perspective on that. Speaking as both a transplant nephrologist, but unusual for a transplant nephrologist, I also practice general nephrology. So I take care of patients with chronic kidney disease. And I'm also the medical director, and I rand on patients in in-center dialysis units as well as home therapies units. But most of what I do is transplant. So before we get started, I have a couple of conflicts of interest to let you know about. I serve on the board of directors of a company called Interwell Health, which is a population health management company that's focused on patients with kidney disease. I also give advice to Fresenius Medical Care, specifically on transplant-related issues, mostly dealing with how to try and increase patients' access to transplantation. And I guess it should just go without saying that what I say here is really my own views. It's not the views of Metrolina Nephrology Associates or Atrium Health or anybody else. So I'll take the credit and the blame. So I'm going to start off with a series of 7 steps that were written and promulgated by Medicare. That's what CMS is, Center for Medicare and Medicaid Services. This is something that they put together within the last year or two to try and help dialysis facilities walk through in a stepwise fashion the steps to transplantation. But I'm going to offer my own editorial comments along here. So don't feel like you need to read these really quickly, because in the next slide, I'm going to walk through some of my own editorial comments.
Dr.
So
Hippen,
we're going to start off.
Excuse me, Dr. Hippen, can you put your slideshow on play from start? We're not seeing it in a full view.
How about
That's
that?
it. Yeah, perfect.
Okay.
Thank you.
Oh, thank you. I'm not a Zoom expert. Here we go. Okay. So let's start off with clinical suitability. I really appreciate what Lori said about patients being their own advocate, because I really believe that too. Medicine is an art, transplantation is an art, and trying to figure out who is and is not suitable for transplantation is, I would say, a moving target. So I think one of the most important things as a patient you can do is to know as much as you possibly can about your medical history. Transplant centers often throw around terms like high risk, and sometimes that label is warranted, but high risk can mean a lot of different things to a lot of different transplant physicians and surgeons in a lot of different transplant centers. So if you find that that label is being applied to you as you're going through the process of trying to get listed for a transplant, find out why and ask questions. There's certainly levels of high risk. Certainly transplant professionals want to make sure that when you do get a transplant that it works well for you, and as much as possible works well the first time and lasts as long as possible. So if they have particular concerns about whether you're going to do well after transplantation, find out why, so that you can figure out for yourself what high risk really means for you, because what high risk means for me is probably less important than what high risk means for you as the patient. Next is recommended by CMS for dialysis facilities and nephrologists to gauge a patient's interest in transplant. If you are somebody who's in an in-center dialysis facility, or if you're seeing a physician in a busy nephrology practice, you probably noticed there's often a lot going on in the office. I think general nephrologists do their best to try and make sure that everybody's medical needs are addressed. But I think, again, it's important. I just want to reemphasize what Lori said, that if you're interested in transplant, it's important that you be your own advocate and you voice that interest and repeat it. It's relatively easy for a general nephrologist to refer a patient for transplant, but what happens after that referral goes off to the transplant center is often a black box to your general nephrologist. So if you're not sure what's going on once you've been referred for transplant, ask. Once you actually get referred to the transplant center, please make use of your transplant coordinator, because your transplant coordinator is, or absolutely should be, your advocate. They are there to help you. They're there to help guide you through the process. They're there to answer your questions. And if they don't know the answer to your questions, they will know somebody who will know the answer to your questions. So this is always new for everybody. It's sometimes easy to forget whether you're a transplant nephrologist like me or a transplant coordinator who's doing this all day, every day. It's easy to forget that this is new for everybody who's going through it the first time. And so sometimes we all just need to take a breath and make sure that the folks that we're talking to understand all the information that's been given to them, because sometimes it can come in an avalanche. And if you have questions, don't be afraid to ask, and make sure that you're comfortable with your coordinator, that this is somebody not only who will answer your questions, but you're comfortable asking those questions of them. And if there is a discrepancy there, ask for a different coordinator, because this is about you. This is for you. And I think transplant coordinators can have a similar relationship as transplant nephrologists to patients. Everybody needs to be comfortable with everybody. Once you actually visit a transplant center, I think it's important to bring a support person. There's a lot of reasons for this. People who are coming down their own path to transplant have different experiences along the way. I see all kinds of different folks who get referred to the transplant center for evaluation. Some folks who've been on dialysis for a long time, or even haven't been on dialysis for that long, are coming to the transplant center on their non-dialysis day if they're doing thrice weekly in-center dialysis, and that can be rough. You know, the fatigue after rebounding from a dialysis treatment can sometimes make it difficult for you to absorb a lot of information all at once. And often transplant centers, in an effort to try and move the evaluation along, will provide you with a lot of information all at once, sometimes with written materials of varying quality. But I found, and patients have told me after the fact, that they often find it helpful if they bring someone else along who can listen alongside them. It's also helpful when you make your first visit to the transplant center that if you have developed questions in advance, that you bring them with you and ask them and take notes, because again, particularly for the first one or two visits, it's going to be a lot of information coming your way. You'll want to refer back not only to the written material, but the answers that you got to your questions when you came to the transplant center. Again, the period between the actual referral to the transplant center and your initial appointments and actually being listed can be a long time. So lots of things can happen along the way. And so here again, I'm going to reiterate what I said earlier, which is that your coordinator is and should be your advocate, and should be somebody who's there to help you. But you also will be better served if you, as much as you can be your own advocate, or if you don't think you can serve yourself well in that position, find somebody who can advocate for you. And if you don't know the answer to a question, please be sure to ask, because the coordinators are there to help and answer your questions. Once you're actually waitlisted, it's really important to continue to be transplant ready, to do what you can to make sure that you stay as healthy as you can be, so that when you do get an organ offer, it all goes as well as it can be the first time. So if you're sick, if you have a medical setback, as much as, and you strongly suspect that this is something that may delay an organ offer, please be honest. Please tell someone. We all want to do this right the first time. We all want to make sure that once you get your transplant, it's not only the right organ for you, but that you're in the best position to do well with it. And then identifying potential living donor candidates. There's probably been a lot of conversation at the Renal Support Network about waiting times for an organ from a deceased donor and the importance of living kidney donation. And it's routine for transplant centers to underscore the importance of identifying potential living donor candidates. But I also know it isn't that easy for everybody. Some patients that I see come from families who have many family members affected with kidney disease or other diseases that make them ineligible to be a living donor. This is an extremely difficult thing for some people to discuss, even with their closest relatives and loved ones. And how to ask somebody to be a living donor is not all that intuitive or straightforward, but most transplant centers that do living kidney donation also have living donor coordinators. And while the primary job of a living donor coordinator is to help living donor candidates through the evaluation process, living donor coordinators also can help recipients think through the best way for them to identify potential living donor candidates, as well as identify what in our center we call living donor advocates or living donor champions. So this is somebody in someone's social circle. It could be a relative, or it could be a friend or someone in someone's community who is not themselves going to be a living donor for one reason or another, but can be the person who understands that transplant candidate's social circle well, and can be the person who makes the ask, who makes it known that a candidate needs a living kidney donor, and can facilitate what can sometimes be a very difficult thing for a transplant candidate to ask. Those donor coordinators have tried and true strategies for doing that. They can give you advice about getting the word out, whether it be by conventional means or through social media, and also help think through who might be a good or not such a good candidate to be a living donor. So let's talk a little bit about clinical suitability for transplant. Again, most categories of patient with advanced chronic kidney disease or end-stage kidney disease do better with a transplant compared to dialysis. So stipulating that, who in general, and again, when I say in general, each of these can have their own exceptions. So I don't mean to suggest that these are written in stone, but who in general is not a candidate for transplantation? Well, if a patient does not want a transplant or expresses no interest in a transplant after being educated about transplant, that's a reason. But there may be many other reasons why a patient declines to proceed with a transplant referral or seems to evince a lack of interest. I think identifying the reasons why is important because at least from where I sit as someone who also refers patients for transplant, this is a conversation and not a single event. I've had patients who have had a lot of concerns and fears about transplantation who over time, as they become more comfortable with the idea, eventually do want referral and do want to learn more. So this is sort of a point to find out more information and see if it's a point that needs to be revisited over time. Active systemic malignancy, this is a sort of a synonym for cancer, is often thought to be a contraindication for transplantation. That being said, there are lots of cancers that with a suitable interval and suitable treatment are not contraindications to transplantation. And even very serious cancers with enough disease-free survival can be present, and yet safe transplantation can transpire. Active ongoing infections are things that need to be identified and treated. And of course, there's a wide variety of different types of infections, and even very serious infections and long-lasting infections are not necessarily contraindications for transplantation. So, the details matter here. Debilitation is a real area of controversy within transplantation. We do know that patients who are significantly debilitated going into transplantation often have significant surgical complications after transplantation, difficulties with wound healing, difficulties with nutrition, and can have higher rates of what are called opportunistic infections. These are infections that occur in someone because they are on immune suppression and they otherwise wouldn't get these infections. So again, the key here is irremediable or not able to be fixed. Debilitation is a relative contraindication to transplantation, but a lot of different types of debilitation can be, if not completely fixed, made at least a little bit better. Again, the whole idea being to position candidates as best they can to succeed after transplantation the first time as much as possible. An important and common, unfortunately, comorbidity in patients being considered for transplant is heart disease, particularly people with coronary artery disease or heart failure, or who've had a history of repeated strokes, which is what cerebrovascular accident refers to. This is probably the comorbidity that as transplant nephrologists, we struggle with the most to try and optimize as best we can before transplant. But some people have such significant cardiovascular or cerebrovascular disease as to not be able to be transplanted. And then psychosocial barriers are another area of controversy, and I would characterize this as a relative contraindication to transplant. There are a number of psychiatric illnesses that are completely compatible with transplant. Here again, I think that if transplant candidates deal with anxiety or depression or other types of psychiatric disorders, being upfront and honest about it is paramount, because in my experience, except in very severe cases of psychiatric illness, these are typically very surmountable barriers to transplantation. But the ones we're particularly concerned about, and I was glad to hear Mandy talk about issues with regard to adherence in patients who are getting transplants in their teenage years, these are behaviors that are not true of everybody, first of all, and can change over time. So I think these are just things to be upfront about and work through. And then substance abuse, again, is another controversial contraindication to transplantation. The world is changing, society is changing, and attitudes towards substance use are changing right alongside it. I think you should ask up front your transplant center about what their criteria are, because I think they've certainly changed over time. I suspect many have changed in the last 10 years, particularly with regard to, say, cannabis use. Those of you who have had the experience of going through the evaluation process at multiple transplant centers will probably become aware that selection criteria vary, sometimes vary a lot between transplant centers. And one of the most common questions I get is why that is. Why can't transplant nephrologists and transplant surgeons agree on relative and absolute contraindications to transplantation at their center? Well, one of the reasons is because transplant centers typically go through a quality assessment and process improvement process. So at any transplant center doing any kind of solid organ transplant, adverse events happen. Kidney transplants fail, patients have adverse events, patients die, and any transplant center who's doing what they're supposed to be doing always goes back and looks at those adverse events and tries to make sure that they don't have a system problem that they can fix to make sure that that didn't happen again. You can't foresee every bad outcome, but as a consequence of that process, and because those processes as they take place in different transplant centers are different, often that results in transplant centers changing their selection criteria around because they're trying to learn from what happened before so that they can make sure that they can provide the best care for everybody going forward. But that's one of the reasons that selection criteria are different across different transplant centers. And if you're not sure about the criteria being used at a particular transplant center that you're being considered listed at, be sure to ask. Your transplant coordinator is a great resource in that regard. So one question that many people with kidney disease ask themselves is whether they should pursue transplant. There are lots of reasons that patients decide not to pursue transplant. What I found in my own experience with my patients is that some patients have bad experiences with transplant, either their own personal bad experience with the transplant, or probably more commonly, there's someone in their dialysis facility who they are friends with whose transplant failed, and so they were afraid of that or didn't want to go through that. Good experiences often don't weigh as heavily as bad experiences, particularly when it comes to trying to think through the fear of the unknown of a transplant for patients who don't have a lot of connections with people who've done well with transplant. I found, at least in my dialysis facility, that it is a kind of a community. I have been the medical director of my dialysis facility for 11 years, and I've rounded there for over 15 years. And I've known many of these patients for a very long time. It's one of the reasons I love being a nephrologist. And it's one of the reasons that although, my heart and my mission is in transplant nephrology, I really do enjoy and I'm grateful to have the opportunity to practice general nephrology because I have gotten to know these patients over these many years and their families and their hopes and their fears. And one of the things that I think is underestimated in some circumstances is that a dialysis unit, an in-center dialysis unit, can be a real community. For some patients, particularly patients whose families are geographically far-flung, who live by themselves, who don't or can't get out much. And so one of the things that I have learned to be sensitive to over time is just how important that community can be and how devastating and sometimes it can be when it's lost, when a patient is removed from that tight-knit dialysis community, given a transplant, and the expectation is, okay, you've got a transplant, go off and live your life. It's not always that simple for everybody. And then again, there's a lot of information out there. The internet is a vast, vast place, and that information is of varying quality. So again, I'll reiterate Lori's great advice, which is to be your own advocate and educate yourself and make sure that the information that you're getting is good information. There is good information out there. I would recommend websites of the National Kidney Foundation and the United Network for Organ Sharing, and I'm confident that the Renal Support Network also has excellent advice out there. Transplant centers often have their own educational materials. Our particular transplant center actually has a group teaching set of lectures where people have an opportunity to show up, ask questions, bring loved ones, family members, and it's a no obligation opportunity to learn more about transplant without committing oneself to the evaluation process. I'm a big fan of peer mentors, which again is one reason I'm very grateful to the opportunity to speak to the Renal Support Network, because that's what the Renal Support Network provides, is peer mentors. My friend, a gentleman who I admire greatly, the late Bill Peckham, who was a home dialyzer for many years and just recently passed away. He was the author of the blog Dialysis from the Short End of the Needle. I keep the name of that blog in mind a lot when I talk to patients about transplant, because as a nephrologist, I'm not on the sharp end of the needle. And I think that sometimes information has just more intuitive plausibility when it's coming from someone who has been where you are. I can describe these things in the abstract, but there's nothing quite like hearing it from someone who's been exactly where you are as a patient on dialysis or a patient with advanced chronic kidney disease thinking about a transplant. Peer mentors are often available through transplant centers, and your transplant coordinator is a good resource in that regard. And again, I know I've said it a million times, but I'll say it again. Please be your own advocate. Remind your rounding nephrologist, remind your multidisciplinary care team, if you're an in-center dialysis facility or a home dialysis facility, about your interest in transplant and asking where you are in the transplant evaluation process, because it can be easy to lose sight of with so many other things going on, maybe even particularly today. So how can you position yourself to succeed once you get referred for transplant? Most transplant centers have a written list of their selection criteria, which can be made available to you. Sometimes it's on their website. If not, your dialysis facility or your nephrologist often can get one and have a copy and provide it to you. Knowing your medical history is extremely valuable. Speaking as somebody who often has to try and piece together medical histories from different disparate pieces of information from lots of different medical records and lots of different hospital systems, you can certainly make things a lot easier and make sure that mistakes don't happen if you have available to you a written summary of your medical problems, your surgeries, your family history, and the medications that you're on, any medication allergies you have, any prior testing for cancer screening and things like that. The transplant center does have folks that can gather all of that stuff, but if you actually have that in hand, you will save the transplant center time, which is going to save you time getting through the referral process and finally to the waiting list. Again, I'll reiterate, being on dialysis is a challenge. You're not always your best self immediately after a dialysis treatment or perhaps even the next day. So having a support person who can listen alongside you, who can take notes alongside you, and who can ask questions is going to be really helpful for you. And, if you have concerns about how well you're going to do in transplant or things that you notice about the transplant program that concern you, please, if you notice something, say something. We, again, want to try and do this right the first time. Notwithstanding some folks on the call who've got multiple transplants and are doing well with it, I think even they will tell you the next transplant is always a little more difficult, a little more challenging than the first transplant. So as much as we can, we want to try and do it right the first time to make that last as long as we can for you. And again, if you find in the course of your evaluation that your barrier is not a medical problem or not clinical, find out what you need to do because many of these barriers, as I mentioned, are surmountable. Find out, what's the bar you need to get over, what resources are available to help you do that. And again, Lori's right, be your own advocate. After the first visit at the transplant center, I think it's a good question to ask yourself, how did it go? Do you feel good about the nephrologists, the surgeons, the social workers, the financial counselors, your transplant coordinator? Did they inspire trust in you? Did you feel like you could ask questions? And did the transplant center give you answers to the questions that you asked? Do you have a feeling that you know what the next steps are and when those are going to happen? What additional testing do you need? What are the next appointments and when are they? Do you have a fundraising goal after speaking with the transplant financial counselor? When is your case going to get presented to the selection committee? And when do you hear about when you're listed? Most centers, in fact, all centers are required to send you a letter indicating that you've been listed for transplant, or in the minority of situations that you've been ruled out for a transplant, but you should get written documentation. But you can often hear about that in advance. And then with regard to looking for living donor candidates, one of the things to keep in mind if you are looking to get listed for a transplant and you have some potential living donor candidates is that most transplant centers have a 2-track system for evaluating people for the waiting list and evaluating people to become living kidney donors. Living donor candidates have to have their privacy respected too, just like your medical privacy is respected. And some centers will actually wait until a candidate is listed before beginning to work up living donor candidates. So one of the reasons why a center may not be getting to your donor candidate is because they're waiting to get you through all of your testing and listed. In the event that they find something in the candidate's workup that means they can't be listed for transplant, they don't want to put the living donor through additional testing that they wouldn't otherwise need. But different transplant centers approach this in different ways, and you should ask. Once you actually complete the workup, it's important to know that referral is not the same as listing. The timeline between referral to the actual waitlisting process can take a long time, sometimes weeks, but sometimes months. But the thing to remember is if you are somebody who's on dialysis, whenever you are placed on the waiting list, your waiting time will be backdated to the start date of your end-stage kidney disease, and that date is listed on a government form called the 2728 form. So if you have been on dialysis for 2 years and you get referred and listed for transplant, your waiting time doesn't start when you're waitlisted. It gets backdated to the dialysis start date on your 2728 form. If you have advanced chronic kidney disease and not on dialysis and get referred and waitlisted, then your waiting time starts when you get listed, even if you then progress to dialysis. Be sure to ask your coordinator whether there's any routine cancer screening updates that can be done in advance, because if you can get those done before your initial visits, then you don't have to wait to get those done, and that can sometimes speed up your waitlisting process. If you are someone who has heart disease and if you have a cardiologist, I think it's a good question to find out if you're due for updated testing and whether you should proceed with that in advance. Sometimes the transplant nephrologist will want to see you first because they'll have very specific recommendations for what kind of testing that you need. But asking about that in advance could also save you some time. Many transplant surgeons will want to look at any radiology imaging that is available of the abdomen and pelvis, particularly to look at the blood vessels in the abdomen to make sure there's good surgical targets to sew in the kidney or the kidney pancreas. So if you've had a CAT scan of your abdomen and pelvis in the last few years, if it's not in the electronic record of the transplant center that you're attending, getting it to them can help a lot. And then another question is whether centers do frailty or functional status testing and what that amounts to. So some transplant programs will do a 6-minute walk test or a walking treadmill test like a modified Bruce protocol. Others have a checklist. So for example, Wake Forest Baptist in North Carolina has an objective a series of tests that they put patients through to check on their functional status testing. And if you're someone who struggles with this, it's worth finding out in advance. For example, if you have prostheses, that can make walking on a treadmill very difficult. Are there alternatives to functional status testing that's more applicable to you? Asking about that in advance and making sure that you're ready for that, I think will also speed up your time from referral to waitlisting. Please make use of your dialysis unit social worker. They are absolutely there to help. And your dialysis unit multidisciplinary team can help too. Most dialysis units have a list of patients that get monthly PRA testing. These are blood tests that get sent to the transplant center every month. And the transplant center uses that to make sure that when you do get an organ offer, that organ is compatible with you. And so sometimes patients don't get their monthly PRA blood tests sent over to the transplant center. Make sure, being your own advocate, just to ask the dialysis facility whether your monthly PRA tests are being drawn and sent, because this can be sometimes a cause of getting passed over for an organ offer if the transplant center has not had a monthly PRA blood test in a couple of months. If you think you may be somebody who would benefit from formal physical therapy or rehabilitation, that's worth finding out in advance and proceeding with that as best you can. Again, this is very much in the same vein of being your own advocate and making sure that you are best positioned to do well after transplant the first time. Occasionally, what will happen in the course of cardiovascular screening is you will have an ultrasound of your heart ordered, and that ultrasound of the heart will show that you have something called pulmonary hypertension. I won't get too far into the weeds on that, but this is something that can sometimes be improved with challenges to your dialysis dry weight. And this is something that the dialysis unit can help with in fairly short order. If you are taking blood thinners or antiplatelet agents for any reason, aspirin, Plavix, Coumadin, Eliquis, or other things like that, your transplant center will certainly have questions as to whether you really need to have that medication or not. Sometimes some people do, sometimes they don't, but just mitigating the risks of bleeding after transplantation, having a conversation between the transplant team and the general nephrology team, and sometimes the vascular access surgeons, are often useful. Again, just positioning you, the patient, as best you can. How do you stay transplant ready? Well, you know, one question that lots of people ask that seems like it should be an easy question to answer is, where am I on the list? It's worth remembering that waiting time, again, is indexed to the start date of dialysis. So people who've been on dialysis for many years, even if they haven't been referred until very recently, once they get waitlisted, can often go very high on the waiting list because of their years of dialysis time. Additionally, very highly sensitized patients who have a lot of antibodies in their blood, can be prioritized for waitlisting, but typically these are patients who have quite a lot of antibodies in their blood. And it's a smaller fraction of the people who just have sort of a few antibodies in their blood. You will sometimes hear that you have been passed over for an organ offer. This does happen. You will sometimes be called in for an organ and discover that the organ isn't suitable. And so you're all ready to go. You've had all your blood tests. You're going to go to the operating room in 12 hours. And then someone like me comes in and says, sorry that the organ isn't suitable. Don't be discouraged. False starts happen. Okay. It does mean that you are likely to get organ offers soon after if one doesn't work out. There is a new change to the allocation system, which we can talk about in the questions if you want, but this can sometimes make it difficult to figure out exactly where you are on the list month over month. If you have changes in your insurance coverage, be sure to let the transplant center know. Most patients with Medicare need some sort of medication supplemental plan, like a Part D plan. If you're thinking about a Medicare Advantage plan, because that's now going to be on offer starting in January of 2021 to patients who are traditional Medicare beneficiaries with ESRD. Be sure to check on the transplant and immunosuppression coverage. That's really important because not all MA plans have the same coverage. And if you don't have a donor and you may be looking at many years on the waiting list, remember I don't have to tell you, this is a journey. So think about all of your options with regard to renal replacement therapy. I often have this conversation with patients who, unfortunately, we end up judging are not candidates for transplant. And I immediately pivot from that conversation with them to talking about, well, how can they maximize their autonomy? One way to do that is, for some people, home therapies, peritoneal dialysis or home hemo. We talked a little bit about identifying a living donor. Again, just like you have a transplant coordinator, there are living donor coordinators too that can help you out. Living donor evaluations have become more complicated, in part because living donor candidates have become more complicated. Just like we have selection criteria for waitlisting, we have selection criteria for living donors at most transplant centers, and they can provide you with that information. And again, transplant centers are trying to navigate this balance between advocating for their patients and trying to get them transplanted with a qualified living donor who's been evaluated and judged to be safe to donate. But we also have to respect the donor's confidentiality. Your transplant coordinator is a good resource for asking for updates on the donor evaluation. So I'm running up on time. This is just sort of a reiteration of what I said before. Probably the most important thing here is to be your own advocate. And I will stop there and take your questions. Thank you.
Whoops. Thank you, Dr. Hippen, for that wonderful presentation. We have a couple of questions here, and I'm trying to figure out how to push the buttons here on my computer. One question is regards to advertising for a living donor. They have concerns that this may impact future employment opportunities. Would love to hear how you educate your patients on that topic.
It's a complicated topic. In one of the very thing that makes social media remarkable, it's the publicness of social media, is also in many ways the downside of social media. When you advertise your need for a living donor on social media, particularly platforms where you don't get to choose who sees it, this is a potential consequence. It's difficult for me to offer advice generally, but transplant centers increasingly have more experience with this. And my recommendation would be, before you indicate your interest or your need for a living donor on social media, talk to your transplant center, talk to the donor coordinators. We all have guidelines on how this can be done in a way that minimizes the risk of unintended consequences while still getting the word out. I myself am a bigger fan of the living donor champion, somebody within a social circle who knows you, who knows people who know you, who can get the word out that way. I actually just find that to be more effective than social media appeals generally.
Thank you. Another question is about wait time. We have a person who has been listed for 4 years on the wait list, but they're not on dialysis. So they can be listed under a 20 GFR, correct? And
that is correct.
It doesn't impact their waiting time at all, right?
That is correct. So if you're not on dialysis, you can be waitlisted if your estimated GFR, whether it's by a 24-hour urine or by one of the GFR equations, is less than 20 cc's a minute.
Then one other question is about caregiver requirements. Different hospitals say you need X amount of money, you need a caregiver, you need different things. Any words of wisdom on that? We need to get to our visits and stuff. So you can't drive and do certain things right after transplant. You're a little loopy sometimes. So
that's right.
Can you just express what your center does?
Yeah. So great question. With regard to caregivers, we typically do not clear patients to drive until after they have seen the surgeon in a post-operative visit to make sure that their incision is fully healed. in part because if someone has a car accident and that incision, and they're driving and they have an incisional problem, that can be a problem. So we typically, that's typically about 4 weeks for most people. Also, the hardest part after transplant is typically the earliest part of the transplant. Your immune system is the most suppressed that it's going to be. That's why when you're going back and forth to a lot of different physicians, you're not feeling the best because you've just had a major abdominal operation. You may have an opportunistic infection at that point and things like that. So, in terms of requirements for a caregiver, it's got to be somebody who has a certain level of flexibility to transport you to A and B, sometimes on short notice, at least for the first, I would say, 4 to 6 weeks after the transplant. Quite often in the course of the evaluation, we also recommend that the caregiver candidate reach out to their employer about FMLA, because we've not had a lot of trouble getting FMLA for caregivers for transplanted patients. The employers in our area are fairly standard. So if you can inquire about that through the caregiver's HR, that can be organized in a way that we're not sort of trying to play catch up after the transplant. Financial criteria really vary a lot across transplant programs. We do have those, but we also are very fortunate in having a program that does everything it can to maximize things like patient assistance programs and a pretty broad reach of our hospital network to try and minimize that burden on patients.
Thank you. One other question is in regards to how often do you suggest people should get their blood drawn post-transplant? I mean, that's, every month, Monica is saying every 3 to 4 months, she is getting her blood drawn.
Yeah. I wish I could say that there's a uniform answer to that too. So right or wrong, in Charlotte, the way we do it is typically twice weekly for the first 4 weeks, weekly through the first 6 months, and every 2 weeks from month 6 to month 12, with visits in between. After a year, I think it's controversial. And it really depends on your transplant center and your relationship with your transplant program. So by way of example, in Charlotte, we take care of nearly 2,000 transplanted outpatients. And we not only take care of their transplant, but we also provide a lot of primary care services for a lot of these patients, because as often happens with patients with kidney disease, the nephrologist often ends up taking over a number of primary care responsibilities. So as a consequence of that, we tend to want to have a closer eye on what's going on, not only with kidney function, but with everything else. It's kind of an axiom of transplantation that the earlier you can find something, the more opportunities you have to do something about it. So I'm probably more on the aggressive side, at least in my opinion, in terms of how often to get labs. I really like monthly labs on patients for the life of their transplant. That's probably too much for some patients, but sometimes it's not enough for others. So I do tend to temper that, though, with the fact that the purpose of a transplant is to give transplanted patients their life and their autonomy back. So I have to be flexible for my patients so that they can, make the most of the life that has been given to them through this amazing surgery. So I usually start with monthly, and if that needs to change, then I think it's just a conversation.
Thank you. And the last question is regarding, when you get listed, how kidneys are allocated, because I've heard of instances where you're listed and you're basically 5 or 6 year wait, but you get a call due to the kidney at the hospital because the person who's in the top position isn't able, and then it kind of goes down the list at the hospital. so they don't waste the kidney. They can't send it to another facility at that time. Can you explain a little bit about that? You always need to be ready for a transplant?
Yeah. Beyond what you finished with, which is you always need to be ready for a transplant, there is a lot of complexity there. So trying to put this in the most straightforward way, when an organ gets offered for transplant from a deceased donor, the donor information goes to a computer in Richmond, Virginia, operated by the United Network for Organ Sharing at UNOS, and they generate a list. It's often 1,000 patients long or more. And transplant centers have an opportunity to go down that list as that organ is offered to a patient on the list by UNOS, and they have to, in rank order, decide whether they're going to accept that organ or not. For very high quality organs, you don't have to go very far down that list of 1,000 patients or so, because that organ's going to be accepted and transplanted fairly early on in what's called the match run. For organs that are, shall we say, higher risk, one may get very far down into the list before that organ gets placed with a particular patient. Sometimes you may go, hundreds deep into that list until that organ gets matched with that particular patient. And in the course of all that, you have to imagine that this is a list that is being gone through over time, and you have different transplant centers who are coming in saying, yes, we're interested, no, we're not interested, no, we're not interested, and eventually it filtering down to kidney plus recipient. Also, transplant centers will often bring in not only the patient who's being offered the transplant, but a backup. So if they bring in someone for the transplant and they do a workup in an effort to get that patient to the operating room, they might find something on an x-ray, on a blood test, or just, on a physical exam and speaking with the patient that suggests that perhaps they shouldn't go forward with the transplant, because anything can happen along the way, particularly now in the COVID era. That's sort of underscores it. But really the backup is just, in case the person who's ahead of them in the allocation order, something's wrong there that suggests they shouldn't do the transplant, there's always somebody there ready to go. So the predictability of that, because of all of those variables, is sort of very difficult to sort out. So I'm not sure that answered the question, but I hope that sort of illustrated the problem with answering the question.
I think you did a great job. I just want to thank you, Dr. Hippen, for sharing your expertise. I have very high regard for transplant nephrologists and nephrologists, because you really are, you give us so much hope. You take care of us for so many years, and you do become family. I mean, I had more renal care professionals at my wedding than my own family, and it's a very, noble profession. So I thank you so much for your expertise. And a shout out to our corporate mission partners for making this happen.